Dr. Cinelli is a senior engineer with records of biomedical engineering and space exploration accomplishments. Her work experiences are biomedical engineering, human factors, mission design, analog missions, and space medicine. She has a bachelor's and master's in biomedical engineering from the University of Pisa in Italy, and a structured PhD in neural engineering from the National University of Ireland in Galway. She's also a graduate of the Space Studies program run by ISU at Delft in the Netherlands. More recently, she completed a postdoc at Tufts University in neuromodulation. She's a fellow of the Aerospace Medical Association, past president of the Aerospace Human Factors Association, member at large of the Aerospace Medical Council, and an invited member of the Mars Society Steering Committee. She's going to talk about the role of AI in space healthcare, which is a topic near and dear to our organization's heart as well. Doctor.
Thank you so much. So I will try to be very concrete and very brief and to show you something I have worked on and that I think it could be valuable, it could be of interest to the audience and to space tech analytics too. I will talk about the levels of care, and the image that you see here on the slide is taken from the NASA standards that was published in 2015. And so space agencies here at NASA, when they decide where to go and what to do and what to bring, they have standards. Okay, when there is a planning of space operation, which is very frequently referred to the question, okay, where do we go right now? So there is a way to plan it from the medical perspective for understanding which type of devices people should bring with them, because it's not that you can bring everything that you would like to, because there is a payload, a maximum payload to reach, and people won't pay for extra payload, okay? And so there is a compromise, there is a link to the payload, but it's also linked to the medical history and to all the possibility of medical condition that could arise during a specific mission. And so that is why planning an operation, a space operation for a crew mission is so complex, because it's not just picking the location and just understanding and anticipating, realistically anticipating what can be wrong from the medical side. And most of those are estimates done with engineering software. Most of them are based on risk assessment and probability analysis. And so here it is interesting to me to see that if you're within LEO, you know, these scientists assume there is a certain moderate risks to have something, to have a threat to health or to life. However, the more you stay, the longer you stay, and the far away you stay, then the risk became more concrete, more severe. And so there is a need to redesign and to rethink about what people can really bring with them. And one of the things that I found really fascinating is that when you look at, for example, Mars, the destination of Mars, which is like, you know, when you go to Mars, you go to the planet and you go back. It's a very long mission, okay? And but even if you say in a permanent settlement on the moon, for example.
Nou,
and so,
hoop ik dat het een beetje stil mag worden.
Could you please mute yourself? Thank you. And so what is very interesting here is that people are thinking and to use autonomous medical care, which is correspond to a level of care number 5, and which is at the last road of the column. And so, but however, they do not provide a really good definition of autonomous medical care, because currently there is no such autonomy. There is artificial intelligent techniques integrated into medical devices, and people are using, and physicians are using, so it is used in medical care, but there is no definition. And from an engineering point of view, it's kind of bizarre, because you can interpret it as you like. However, there are so many limitations when you think about the introduction of autonomy in medicine and medical care that are not really, I wouldn't say considered, but we're not yet at the point of considering those. Because it's not just producing an algorithm, it's just understanding how the algorithm itself can be a threat to human life. Okay, and what are the risks that the algorithm can introduce to safety? It's a very coercive and closed loop process. But for making a long story brief, I wrote a paper about artificial intelligence in space healthcare, which was already published, but here to provide you some differences. So what I think be happen to my view is that you can't just copy artificial intelligence from medical care into the rest of healthcare and apply that to space medicine. That won't work. And the reason is because of the data. Data algorithms are training on data sets where people are exposed to the gravitational fields, while in space it's a completely different, and we do lack data, and for different reasons, okay? Because initially the intent was not to build a huge data set, was to share the data with the community for scientific purposes, but that's way different from a data set for running artificial intelligence algorithms. Okay, so that is a big difference. So you can't expect to have the same outcomes that you have on the ground. If you lack data, you might end up having an algorithm, but the sensibility and the accuracy of the algorithm is just off. Okay, from the expectation and compared to the risks that astronauts have, and so. And then the environment. Most of the time, the artificial intelligence that we use in Earth is very specific to very how can I say, to constrain, to very, it's a very contextualized application most of the time. So when you include medical history for understanding how the person will stay for way longer, the environmental data is very complex because there are data about all of this type of information, but it's not collected and provided in one just package, and then you can be ready for usage. There is a lot of complex things about, medical data. For example, when an astronaut is on the ISS, on other space vehicle, the conversation that the person have with the flight surgeon is private. And so if there is any very specific information, very key information, that is essential for understanding what is happening in the person, the flight surgeon might won't tell you, okay, because it's a confidential information. And so some data are classified, they are underreported. And so for the data that, like, for example, people like myself in the private industry might get are just a few compared to those that are, classified underreported. Still, there are so many things that we don't know, because most medical conditions are uncharted, and we have an idea about what could happen, but we cannot guarantee that, because it's not space medicine. It's aware, it refers to the astronaut population. It's not precise medicine yet, so it can't be specific. The doctor, for example, might tell you, okay, you might have 30% of chances to have something, but it's not based on your own medical history. So it's not specific on the person yet, but we are getting there. One of the things that I think could be a concern is that when the governmental agency and the private industry comes together and joins, there is a bit of differences, because most of them, like most of the private ones, are business driven. And while the governmental agency, they have a huge heritage in operation, they're purpose driven. And so when you're producing a device that is business driven, it doesn't work. It works on different standards compared to that, to those that have been developed for purpose-driven application. And so from an engineering point of view, basically you're speaking two different languages, but you don't have the vocabulary that can tell you what's in the other. Okay, so it's very complex scenarios. And then there is the consideration that, you're producing something, but it has to fit in the regulation on the space law, because it's in space, it's not the local regulation. And sometimes it's really hard to get through. And just because, there is a law in artificial intelligence, it's getting there, but we're just starting. So it's really hard to understand when something is ethical or not. And so it's very complex, but I think it's so fascinating. However, what I think is very interesting is that although the NASA has this ambition to, and they do recognize the use of frontier technology, let's put it at large, frontier technology for long-term human mission, for human exploration in a long-term operation. But however, the same people from another team, they do recognize that there is no immediate benefit in investing in technology development if the product will not be ready for the intended mission. Therefore, that's say, so if it takes 40 years to produce AI, and we are not getting there in time for the mission because the launch is 5 years before, then hey, you go with something that you already have, which is crazy from a medical point of view, because there is a huge risk of exposing a person to a life-threatening event without providing a concrete countermeasure. And it is in a way hard to imagine that could be possible, but indeed it is. So it's a sort of paradox between what we really want and what we actually can achieve within the time that we have. And it is fascinating because I think this is opening up a lot of opportunities for industry and for research centers to come together and to try to identify gaps and a solution to the current state of AI. So that said, I would close my talk here just for the purposes of save time and to be respectful of the kindness that you guys gave me and to let other speakers to talk after. So thank you so much for your time.
Thank you, Doctor.